Good evening, esteemed colleagues. My name is Marko Djurdjevic, and I am proud to represent our pharmaceutical company, AlivitPharm, based in the heart of Herzegovina, in a small town called Ljubljana. I can confidently say that our company is backed by over 7 years of dedicated research, collaboration with domestic and international experts, and the application of innovative pharmaceutical technologies, all aimed at providing comprehensive support in the prevention and treatment of various health conditions. One of our key successes lies in the controlled cultivation of medicinal herbs and garlic on the fields of Herzegovina, ensuring high-quality raw materials. This approach allows us to standardize our raw ingredients, guaranteeing consistency and efficacy in every product. Based on this foundation, we conduct clinical studies that further validate the safety and effectiveness of our formulations. Additionally, our approach is built on what I would call evidence-based synergy. Why evidence-based synergy? We have scientifically proven the antioxidant potential of the mixture found in our soft gelatin capsules at the Faculty of Natural Sciences in Belgrade. The results show that the antioxidant potential of the mixture is greater than the sum of its individual components, 20% to 30% greater, depending on the product. This gives us the right to use the term synergy. As a pharmaceutical company, AlivitPharm is the only company in the region utilizing advanced pharmaceutical technology to encapsulate active ingredients in soft gelatin capsules. Why is this important? It enables us to produce top-quality products with superior bioavailability. Our innovative production method ensures rapid and complete absorption of active ingredients, resulting in a more efficient therapeutic response. Fermented garlic, known globally as black garlic, has been adopted as part of our branding to expand our offerings to international markets. Today, AlivitPharm is present in over 10 countries worldwide, with extremely positive results from the use of our products. A key element of our approach is the inclusion of medicinal herbs native to our region. This is crucial because, for centuries, these herbs have been used to treat various medical conditions. We believe they are well suited to our genetic makeup, allowing the body to connect more easily with the natural ingredients that are part of its cultural and biological heritage. All the factors we've discussed, controlled cultivation, ingredient standardization, clinical studies, innovative synergy in pharmaceutical production, the use of local medicinal plants, and soft gelatin capsules, form the foundation of our unwavering commitment to quality. This production approach not only improves our products but has also enabled us to achieve the highest international standards of quality in pharmaceutical manufacturing. As a result, AlivitPharm has earned GMP, ISO 22000, HACCP, and Halal certifications. These accolades confirm the effectiveness and quality of our products, ensuring they are reliable and safe for users worldwide. AlivitPharm combines the traditional healing properties of natural ingredients with the latest pharmaceutical innovations, setting new standards in health and pharmaceutical industries. Our goal is clear: we aim to continue developing scientifically validated products that merge the power of nature with pharmaceutical innovation, contributing to better health and well-being for people around the globe. It is my great honor to introduce Professor Miodrag Kirstic, who will share his expertise in a lecture titled, "Are There Innovations in the Treatment of Liver Damage and Dyspepsia?" Thank you for your attention.
Good evening, everyone. It is a great honor and pleasure for me to be with you this evening in this way. Today, I will talk about non-alcoholic fatty liver disease, which has become a very common condition. I will also address the most common conditions, such as GERD and dyspepsia, perhaps in a slightly different way. Let us begin with non-alcoholic fatty liver disease. This term was first mentioned back in 1842 by Sir Thomas Watson. Around 180 years have passed since the introduction of the term fatty liver. Not so long compared to some other diseases. However, you see, during the first 100 years, almost nothing was known or written about it. In the last 40 years, however, there has been an exponential increase in the amount of medical literature on the topic of non-alcoholic fatty liver disease. There is certainly a valid reason for this, and we will address that later. I like to present cases from everyday practice in my lectures. This is not a hypothetical, made-up patient. This is my godmother's aunt, who even agreed to share her picture, which we will see later. She has a very interesting medical history. She first came to me, a hepatologist, at the age of 78. The first manifestation of her illness was ascites and varices of the first and second degree. She had clear signs of liver cirrhosis. She immediately said that she had, of course, never consumed alcohol, which is indeed true. However, she had an interesting medical history. She had been ill since the age of 14. She had arterial hypertension for the past 20 years, type 2 diabetes for 14 years, and high blood lipids for at least 30 years. She did not have viral or autoimmune diseases. This is my Aunt Daisa. Initially, her liver disease was compensated. We conducted a liver biopsy, which showed that she had non-alcoholic fatty liver disease at the stage of cirrhosis. There are many such patients around us. Fatty liver disease is traditionally divided into alcoholic and non-alcoholic. Both have the same spectrum, consisting of simple fat infiltration, steatosis, fatty hepatitis, alcoholic or non-alcoholic steatohepatitis, and, eventually, cirrhosis and liver cancer. Histologically, these patients cannot be distinguished, the only difference is that one group consumes alcohol while the other does not. According to the prevailing definition, which is still valid, steatosis refers to the accumulation of fat droplets in the form of triglycerides in more than 5% of hepatocytes. If hepatonecrosis, inflammation, and potential fibrosis are also present, we immediately diagnose steatohepatitis. This whole issue is not so simple. From 1980, the definition I just mentioned was valid. However, in 2020, 40 years later, this definition was replaced with the term MAFLD, an acronym for Metabolic Dysfunction-Associated Fatty Liver Disease. It turned out that even this definition was not entirely adequate. At the end of 2023, less than a year ago, a new definition was introduced. It states that these patients have MASLD, which stands for Metabolic Dysfunction-Associated Steatotic Liver Disease. Due to the stigmatization associated with the term fatty, the term steatotic was introduced. Why am I mentioning this? Because in the literature of the coming decades, and probably centuries, the term MASLD, an acronym for Metabolic Dysfunction-Associated Steatotic Liver Disease, and Steatotic Hepatitis, MASH, will likely prevail. What has new technology revealed and indicated? There is no strict division between non-alcoholic and alcoholic liver disease, between metabolic and alcoholic liver disease. Most of these individuals consume small amounts of alcohol. How much alcohol is permissible for individuals with fatty liver disease to maintain it as predominantly metabolic liver disease? Conversely, at what point does it shift to predominantly alcoholic liver disease? Globally, it has been arbitrarily determined that dominant alcoholic liver disease is classified as fatty liver disease, where men consume more than 2 drinks per day, and women consume more than 1 drink per day. Women are twice as likely to develop this disease compared to men, which is why their threshold is lower. Thus, consuming up to 2 drinks per day for men and 1 drink per day for women is considered normal alcohol intake. In these cases, patients with fatty liver disease are diagnosed with metabolic fatty liver disease. So, what else is crucial? Differential diagnosis of steatotic liver disease. In addition to fatty liver, there must be at least one cardiometabolic factor. Cardiometabolic factors align with those for metabolic syndrome, such as a body mass index, BMI, greater than 25 or a waist circumference exceeding 94 centimeters in men and 80 centimeters in women. Blood glucose levels above 5.6 millimoles per liter are also included. To recap, the entire spectrum of fatty liver disease includes steatosis, simple triglyceride infiltration, steatohepatis without fibrosis, early stage, moderate fibrosis, and advanced fibrosis, culminating in liver cirrhosis. This is an evolutionary disease. Observe the progression of non-alcoholic fatty liver disease, from steatosis to steatohepatis without fibrosis, to steatohepatis with fibrosis, represented by blue markers, then to liver cirrhosis, and finally, though not least importantly, liver cancer. The specifics of liver cancer caused by fatty liver disease will be discussed later. Why is fatty liver disease considered a trendy disease today? Because it is the most common liver disease. 30% of adults worldwide have non-alcoholic fatty liver disease, a staggering percentage. 1 in 3 adults is affected. Among all liver diseases, fatty liver disease accounts for 45% of cases. It has surpassed viral hepatitis B and C in prevalence. The trends are alarming. In major countries like China, France, Germany, and the United Kingdom, the number of people suffering from severe forms of this disease is projected to double from 2015 to 2030. Currently, we are halfway through this process. What does this mean in absolute numbers? Look at the data. In China, the number of people with cirrhosis will rise from 1 million to 2.5 million. In Germany, it will grow from 100,000 to about 400,000 cases. One pressing question is, what will happen in Serbia? We are not isolated from the rest of the world, and the same trend will apply to us. Most young doctors starting their careers today will encounter patients with advanced liver disease in the coming years. What is particularly troubling is how prevalent this disease is among young people. One of the award-winning studies presented at a recent global congress revealed that 1 in 5 people under the age of 24 has fatty liver disease, that's 20%. Think back to when we were younger, almost everyone was slim. Back then, perhaps 1 in 20 or 30 individuals was obese. Today, 1 in 5 has fatty liver disease. Earlier, I mentioned hepatocellular carcinoma. Currently, hepatocellular carcinoma in the majority of cases, about 25%, is caused by non-alcoholic fatty liver disease, surpassing hepatitis C or B. This represents a stark epidemiological shift compared to 2 decades ago. The longer this disease persists, the higher the likelihood of developing non-alcoholic liver cancer. What's concerning here? Traditionally, we believe that carcinoma only develops in the presence of pre-existing cirrhosis. Today, we know that in individuals with non-alcoholic fatty liver disease, carcinoma can develop even at the stage of steatohepatis, and potentially even during the stage of simple steatosis. Why is this important? Screening policies for these patients must change. Ultrasounds should be performed more frequently to identify individuals with potentially operable liver carcinoma as early as possible. Various studies show that steatohepatis-associated hepatocellular carcinoma occurs in 25% to 65% of patients who do not have cirrhosis at the time of diagnosis. What do surgical trends reveal? In France, for example, over the last 20 years, the profile of patients undergoing surgery for hepatocellular carcinoma has shifted. Previously, only 2.5% of these patients had fatty liver disease. Today, that number exceeds 25%. These are dramatic epidemiological changes. According to some studies, 63% of patients who develop carcinoma due to non-alcoholic fatty liver disease did not have cirrhosis, compared to just 7% of those with chronic hepatitis C. What is significant in the pathogenesis of this disease? It is present in 60% to 80% of obese individuals, 40% to 90% of those with type 2 diabetes, and 30% to 70% of individuals with dyslipidemia. We must not assume that the disease will always occur in the obese and never in the lean. Rarely, there are phenotypes of healthy obese and unhealthy lean individuals. These should not mislead us. The majority of affected individuals are obese, most have insulin resistance, and many also have diabetes mellitus. As hepatologists, we often only see the tip of the iceberg. Globally, there are now more obese people than those who are undernourished. Over 1 billion people worldwide are considered obese. Among them, 50% to 60% are estimated to have non-alcoholic fatty liver disease, a staggering 500 million individuals. With 380 million people diagnosed with diabetes mellitus, a figure expected to rise to 550 million by 2030, fatty liver disease is present in 60% to 70% of cases, with steatohepatis in 25%. What do major epidemiological studies say? They indicate that globally, non-alcoholic fatty liver disease is associated with type 2 diabetes mellitus in 55% of cases, and in Europe, this figure reaches 68%. This represents a vast number of individuals affected now and in the future. How do we perceive this disease today? It's important to emphasize that we now view it as the hepatic manifestation of metabolic syndrome, rooted in insulin resistance. Clinically, this syndrome manifests with central obesity, type 2 diabetes mellitus, arterial hypertension, cardiovascular disease, and malignancies. Insulin resistance is at the core of this syndrome, and remember that. It holds the key to numerous pathophysiological issues. Let me stress that fructose is poison number 1. Fructose should never be considered a healthy sugar. Sitting kills. This is no longer a point worth debating. People must be encouraged to stay physically active because sitting in armchairs is equivalent to a death sentence in the long term. Now, let's return to the pathology of non-alcoholic fatty liver disease. First, what does insulin do? Under physiological conditions, insulin is a clear trophic hormone. What does it do? It suppresses lipolysis in adipose tissue. In short, insulin is the hormone that enables excess energy to accumulate in our body as fat in adipose tissue. What happens when insulin cannot perform its function due to insulin resistance? We get lipolysis, the breakdown of fats in adipose tissue, which causes a massive influx of triglycerides and fatty acids into the bloodstream. The liver acts like a selective sponge, absorbing these free fatty acids and drawing them into itself. This is how fatty liver disease develops. That is just the beginning of the misfortune and the onset of damage. What happens next with that enormous amount of fatty acids? They attack our mitochondria and lead to oxidative stress. This oxidative stress further contributes to the generation of free oxygen radicals, which worsen liver disease and trigger a cascade that can lead to hepatocellular carcinoma via non-alcoholic steatohepatis. What is the prognosis of non-alcoholic fatty liver disease? The risk of cirrhosis is 1 to 2% over the next 20 years from the moment a person develops fatty liver disease. For those with fatty hepatitis, the risk of cirrhosis is as high as 12% over the next 8 years. Why have I frequently mentioned the term fibrosis or scar tissue? It's because the prognosis of any mortality depends on the degree of scarring, exclusively on the degree of fibrosis. Both liver-related and non-liver-related mortality hinge on it. Fibrosis should be feared like a burning fire because it is what shortens a patient's life. How do we view non-alcoholic fatty liver disease today? We regard it as a systemic disease associated with a broad spectrum of both malignant and non-malignant conditions. It is linked to polycystic ovary syndrome, chronic kidney failure, cardiovascular diseases, type 2 diabetes mellitus, obesity, psoriasis, and numerous malignancies, both digestive and non-digestive. It is truly a scourge of the 21st century. What do people with non-alcoholic fatty liver disease most commonly die from? Not from liver disease but from coronary artery disease. Non-digestive malignancies rank second as a cause of death. What are the most common non-digestive malignancies? Colon cancer, breast cancer, and liver disease itself ranks only third as a cause of mortality among these patients. How to diagnose people with non-alcoholic fatty liver disease? They are everywhere around us. Currently, population-wide screening is not recommended. People at high risk are all obese individuals, everyone with type 2 diabetes, and those who are morbidly obese. These are the people we should primarily target for diagnostic testing. How do we diagnose them? Most often, these people present in primary healthcare settings with mildly elevated transaminase levels may be 50% above the upper limit of normal. The standard diagnostic approach suggests these patients should be referred for ultrasound. On ultrasound, fatty liver often appears as a bright liver, much lighter than the kidneys, unlike a normal liver, which is not. But it's not that simple. For the liver to appear fatty on ultrasound, at least 30% of hepatocytes must be filled with triglyceride droplets. Recall from the beginning of my presentation that steatosis is when more than 5% of hepatocytes are filled with fat. So, we have a large gap between 5% and 30%, where people may have fatty liver but a normal ultrasound that doesn't easily diagnose it. What have studies in France shown? What happens in the asymptomatic population? People who have had a fibroscan, a technology that has never fully caught on in Serbia, show that seemingly healthy individuals have between 0.7% and 7.5% who exhibit varying degrees of scarring in the liver. This is not a simple matter. What does the doctor in primary healthcare have at their disposal? How can they assess which patients to treat and which to refer to a specialist hepatologist? They can perform an ultrasound if they clearly see fatty liver, but ultrasound is not universally available everywhere. So, what diagnostic tools does the doctor have? There are 2 scores that can be easily calculated via smartphones. Thankfully, today, everyone has smartphones. These are the FIB-IFA score and the non-alcoholic fatty liver disease fibrosis score. These help identify patients at the highest risk of developing a more severe form of the disease, and those patients should be referred to a specialist hepatologist immediately. Here's an example I've extracted. I regularly use this FIB-IFA score. It's important to know the patient's age, transaminase levels, and platelet count. Based on that, we just input FIB-IFA into the internet, and a form appears where we can enter these data, and we will know exactly that if the value is less than 1.45, the probability of advanced fibrosis is very low, and the patient can be treated in primary healthcare. Similarly, with the non-alcoholic fatty liver disease fibrosis score. Here, we need to enter the body mass index and whether the patient has diabetes or not. This is also a very convenient score that can be done for free on smartphones. So, once we diagnose non-alcoholic fatty liver disease, we need to approach its treatment. This leads us to the key problem. How do we treat this disease, especially non-alcoholic steatohepatitis? Currently, there is no medication approved by the European Medicines Agency or the US Regulatory Agency for the treatment of non-alcoholic steatohepatitis. Numerous drugs have been tested. Thousands of studies have explored physical activity, weight loss, diabetes therapy, the administration of vitamin E, selenium, and so on. So far, none have fully met the criteria to be considered effective. What does it mean that there is a place for supplements and a place for lifestyle changes? The first lifestyle changes are diet and exercise. And despite Garfield saying that a diet with exercise is like dying with the letter T added, it is necessary. But look at what studies say. What percentage of people are able to lose enough weight to achieve resolution of steatosis and fibrosis? Unfortunately, the number is small. So, for significant regression of fatty liver changes and significant regression of fibrosis, a 10% weight loss is required, and only 10% of people are able to lose 10% of their body weight in a year. Clearly, weight loss is not as easily achievable as it is often portrayed. The Mediterranean diet can certainly help, but what does the Mediterranean diet really mean? Many people recommend the Mediterranean diet without even knowing what it actually involves. There is space for cakes in it, but rarely. There is space for red meat, but rarely. Vegetables, fruits, olive oil, nuts, sitting while eating, cooking while eating, not fast food, exercise, and so on dominate. It's a complex lifestyle change. In short, it includes a lot of olive oil, fruits, vegetables, fibers, nuts, fish, and seafood. This is very important for achieving a Mediterranean diet. What if diet and physical activity don't help us? What do we do next with these patients? First of all, do any medications help or not? Statins definitely help. They should be given in non-alcoholic fatty liver disease if patients have elevated cholesterol levels. That's undisputed. Even if they have elevated transaminases, statins are still welcome. Metformin is also beneficial. Which medications have been widely tested? They include pioglitazone, vitamin E, obeticholic acid, elafibranor, liraglutide, and none of them have shown to be that effective. It's not that they're not helpful, but they are not effective enough to become a recognized treatment for steatohepatitis. Does giving small amounts of alcohol help people who are teetotalers and have fatty liver disease? Yes. A small amount of alcohol can help these people improve their condition. Coffee is a precious remedy. Up to 4 cups of coffee a day can contribute to much better outcomes for patients with non-alcoholic fatty liver disease. Among spices, cinnamon takes the top spot. This is something we can do through non-pharmacological means. Now we come to one of my favorite topics, whey. In Serbia, whey is the most accepted remedy for treating liver diseases, and there is not a single household that doesn't talk about how beneficial whey is. I am one of the haters of whey, and I will explain why. It has been promising for over 2,000 years, but so far there is no clear evidence of its benefits. The most interesting indication is non-alcoholic liver disease. Side effects are not rare at all. We lack quality studies that would confirm that it helps. The last time I researched whey, I found 6,278 references dealing with whey, mostly in the pharmaceutical industry. However, when it comes to the liver, the number of references studying the medicinal properties of whey is fewer than 10, around 7 or 8. The highest level of evidence I found was, for me, simply ridiculous. It doesn't reduce liver fat infiltration, it doesn't reduce body weight, but it can prevent the worsening of existing liver fat infiltration. Please, this is a laughable conclusion. There is no evidence that whey helps, and the side effects are not small. In fact, they are more common than we think. What can we say about garlic? My predecessor mentioned how much effort the company put into fermentation and making an adequate product from garlic. First, I must clarify a few things to avoid confusion. In Anglo-Saxon literature, garlic refers to what we traditionally call garlic, while onion refers to the bulbous onion we know. When garlic undergoes fermentation due to high temperature and humidity, it darkens and turns black. This is called black garlic, but it's not black onion, it's garlic that has turned black. I jokingly say to my friends at AlivitPharm that we should call this product black and white garlic in our country, but it's actually called black garlic. So, it's garlic that has darkened under fermentation. Garlic itself, as a substance, has been known throughout history as a powerful antioxidant. It was mentioned in both ancient Egypt and Rome. It was given great importance, and there is not a single person in the world who will tell you that garlic is not healthy. What does fermentation achieve? It significantly increases its antioxidant properties by 15 to 20 times. Why fermented? Because the unpleasant smell and taste of raw garlic are reduced, making it much easier on the stomach. The concentration of antioxidants increases. All the unwanted properties of regular garlic are replaced by this fermentation process. Some gelatin capsules were mentioned. They have their advantages because of their shape, which is easy to swallow. These supplements can be recommended for people who have swallowing issues. They are made from bovine gelatin, which increases the bioavailability of the active ingredients in them. We've already discussed how important the synergy of fermented garlic with medicinal herbs is. What does synergy mean? By combining several beneficial supplements, the overall potential of a particular supplement for treatment is increased. Different medicinal herbs, when combined with fermented garlic, such as those found in the products I work with, black garlic hepatocare and black garlic digestive, enhance the primary efficacy. A few words about black garlic hepatocare. What's in its composition? It contains oily solutions, an oil extract of fermented garlic in soybean oil. It also contains an oil extract of dandelion root, which also has a pronounced antioxidant effect. There's also yarrow, immortelle, and other plants known to have protective effects in various liver diseases. It also contains vitamin E, which I mentioned earlier as one of the substances that plays a very significant role in studies as a treatment, but so far, it hasn't reached the highest level of efficacy. Vitamin E in small doses is part of black garlic hepatocare. This product has numerous applications in modern hepatology. Primarily, it's used for non-alcoholic fatty liver disease. We shouldn't underestimate patients who consume alcohol excessively but have decided to quit drinking. These patients need psychological support and need to be given a treatment they can trust. It's very useful for people who drink but want to quit. In combination with statins, it neutralizes the negative effects of statins, which lead to reduced transaminase levels and reduces the risk of liver failure. It also has hepatoprotective effects for individuals taking, for example, large doses of anti-inflammatory drugs. It also protects the liver in patients on chronic medication therapy. This polypharmacy is becoming an increasingly common indication for giving supplements with hepatoprotective effects, and black garlic hepatocure certainly falls into this category. As you can see, it is dosed 3 times a day, 1 capsule during or after meals. It can be given continuously for 3 months, and then we usually make a break to assess its therapeutic effect, measure transaminase levels, and perform an ultrasound. After that, the therapy can be repeated if necessary. So, I won't go into too much detail about the mechanism of action, but the dominant mechanism is the antioxidant action of garlic, which has been drastically increased by fermentation. Now, a few words about diseases associated with hydrochloric acid secretion, which dominate contemporary practice today. These include GERD, gastroesophageal reflux disease, functional dyspepsia, drug-induced damage, peptic ulcer disease of the stomach and duodenum. You see, among the 10 most common reasons for seeing a gastroenterologist in the United States are reflux disease, abdominal pain, gastroenteritis, dyspepsia, gastritis, and so on. The problem with these functional diseases is that they often overlap, so we have overlapping syndrome of reflux disease, IBS, ulcers, functional dyspepsia, etc. The main symptoms of GERD are heartburn and regurgitation. This is not surprising, but in these patients, there are often additional symptoms like gastric pain, bloating, flatulence, and belching. You have no idea how many patients consult gastroenterologists for flatulence, bloating, and belching. These are extremely common symptoms. On the other hand, we have dyspepsia. What is dyspepsia? It is a general term for pain or discomfort in the epigastrium, which can be episodic or constant. According to the latest criteria, which have been valid since 2016, there are 2 types of dyspepsia. There's the epigastric pain syndrome, which was once called ulcer-like dyspepsia, characterized by gastric pain and a burning sensation in the epigastrium, but there's also a rather common postprandial distress syndrome, which occurs after eating and is characterized by a feeling of fullness and early satiety. This feeling of fullness and bloating is something that often drives people to see a doctor or go to a pharmacy. How common is dyspepsia? The overall prevalence is around 20%. 1 in 5 people has dyspepsia. The highest prevalence is 29%. It's more common in women, smokers, and people who use non-steroidal anti-inflammatory drugs. What are its symptoms? In addition to pain and postprandial bloating, there's bloating, early satiety, belching, nausea, and vomiting. I frequently encounter bloating and flatulence as very common symptoms in daily life. It's most common in people between the ages of 20 and 40. Around 50% self-medicate, while only 25% go to a general practitioner. Dyspepsia accounts for 30% of absenteeism from work and school every year, and 40% of consultations with gastroenterologists. Dyspepsia and GERD are extremely common diseases. What's important? When should a patient be referred to a gastroenterologist? When can a primary healthcare provider or a pharmacist in pharmaceutical care approach the treatment of patients with dyspepsia or GERD? If someone is over 45 years old, they must see a doctor. If there are alarm symptoms, which include anemia, sudden weight loss, difficulty swallowing, and persistent vomiting, these are red flags. What does a red flag mean? It means that any treatment must be approved by a gastroenterologist. These patients should not be treated by primary healthcare providers or pharmacists. You have enough other patients who do not have alarm symptoms, are under 45 years old, and to whom we primarily recommend reducing factors that lead to dyspepsia, such as stopping smoking, reducing alcohol and caffeine intake, losing weight, and reducing stress, avoiding tight shoes and clothes, and sleeping with the right pillow. What if this alone is not enough? One of the very good supplements available on the market is once again the black garlic supplement, but this time it's not Hepatocare, it's black garlic digestive. In its composition, in addition to fermented garlic, which is now in an oil solution of olive oil, there are proven herbs that we know work very favorably for patients with dyspepsia, such as oil extracts from chamomile flowers, peppermint flowers, and cumin seeds and fruit. Cumin was once given to babies. It also contains oil extracts of angelica root and rosemary leaves. All of these stimulate peristalsis, accelerate the elimination of gases. Look, this is the effect not only of black garlic, but also of the extracts of peppermint, cumin, chamomile, and so on. This reduces postprandial bloating, decreases bloating, and this supplement has been shown to be very useful for patients with functional dyspepsia. So, we are dealing with something completely new on our market. These are supplements containing the best of garlic. Such supplements have not been available from me until now. Now I'm talking about digestive, which is also taken 3 times a day, one during or after meals. Its effectiveness is assessed after 3 months, and if needed, its use can be extended. It can be used along with prokinetics and proton pump inhibitors. It can be added to various therapies, and it's not contraindicated with them and has shown to be very effective. My strong recommendation is for people to use these supplements. I really tried to leave enough time for discussion. I would like to thank you again for your attention, and I'd love for us to now discuss everything I talked about tonight. Thank you.
Good evening once again, everyone. Professor, I would like to thank you for the excellent lecture. A few questions have arrived, so we can answer them now.
Well, if you don't mind, I would like to start. There is an interesting question: can digestive and Hepatocare be taken at the same time? If needed, why not? One does not exclude the other. The next question is very interesting: what about silymarin? This is an interesting question. At the beginning of my presentation, I mentioned that no drug currently has approval from the world's largest regulatory bodies for use in non-alcoholic fatty liver disease. What does that mean? We should try available options and supplements that have a known mechanism of action. I would never say that silymarin is not effective, but I will say that black garlic Hepatocare certainly helps a lot. I am very satisfied with the results in my patients. Next question: if fructose is bad for the liver, should fruit be excluded from the diet in non-alcoholic fatty liver disease? No. This is a great question because not all fructoses are the same. The fructose found in sweetened juices is disastrous. There is a big difference between the natural fructoses found in fresh fruit and those found in juices. For example, in Africa, the consumption of sweetened juices has increased 4-fold in the last 10 years, and at the same time, the number of people suffering from fatty liver has quadrupled. What does that mean? Does it mean that natural fruit is allowed? It doesn't mean that someone should eat 4 kilograms of bananas a day. A small, moderate intake of fresh fruit is certainly welcome, although vegetables are healthier than fruit. That's the truth.
We have a few more interesting questions. In your opinion, is it better to take it before or after a meal?
Better after a meal. With or after a meal. Both hepatocare and digestive are better taken after a meal.
What are the limitations in use, contraindications? I will say that all supplements, due to the anticoagulant potential of garlic, should not be given to patients on anticoagulant therapy, for example, those on heparin, warfarin, acylcumarol, and of course, they should not be taken 7 days before or after a surgical procedure.
Probably one of your colleagues did not listen to the presentation all the way through. Can black garlic hepatocare be recommended to people with fatty liver caused by alcohol consumption? Yes, certainly. I was the first to say that this is one of the most important indications along with non-alcoholic fatty liver disease. It is also alcoholic liver disease in people who are motivated and want to get treated. Absolutely.
The last question for tonight's webinar is whether digestive and hepatocare interfere with the other therapies of the patients.
No, they absolutely do not interfere, and that's something very good. So, they do not interfere. They help those patients who are taking proton pump inhibitors, H2 blockers. It's perfectly fine, they can be given.
All that remains is to thank all the webinar participants and to thank you, Professor.
Thank you. Now, a few interesting questions have arrived. What mechanism explains how a small amount of alcohol helps with non-alcoholic fatty liver disease? I don't know. I was surprised when I read this study. This study was awarded at the American Hepatology Congress. It was conducted by tracking around 1,800 patients. It turned out that a small amount of alcohol worked well for these people. I don't know the exact mechanism. After how much time can we expect results? This is a great question. For people who are taking digestive, you will already see that they willingly go to the pharmacy and take the supplement on their own after 15 or 20 days. Bloating is a common problem, and you wouldn't believe how often people come to see gastroenterologists because of it. That's all about digestive. As for hepatocare, longer use is needed. It takes a few months, 2 or 3 months, for people to take it consistently. There was a question about acylcumarol and warfarin. Can hepatocare be recommended with rivaroxaban? I think it can. I can't say 100%, but what do you think, Marco?
Yes, we have studies that show we can safely use it with rivaroxaban.
The duration of use and whether a break is needed. I mentioned that the therapy should be evaluated after 3 months. Hepatocare should definitely be used for 3 months, and after that, liver enzymes should be measured, assess how the patient is feeling, and if necessary, it can be discontinued or continued. A break of about 10 to 15 days can be made. The composition consists of natural ingredients, fermented garlic, and oil-based solutions of well-known herbs that have been proven effective through experience and science. The good thing is that we cannot really expect any negative effects. Also, what's very important, this is not a supplement with 50 different components in its composition. You know that there are products on the Western European and American markets that are overloaded with ingredients. I often see people who take supplements, and when I see what they are made of, it's 50 components. Then, you don't know how they interact, what reactions there will be, what effects to expect, and so on. That's it. I don't know if we've covered all the questions, but as far as I can see, I think we've answered them all.
We have literally answered all the questions that were submitted. I will repeat myself, I thank all the participants, thank you Professor for your wonderful lecture and your time. Thank you on behalf of our pharmaceutical company, AlivitPharm.
Thank you, and thanks to all the people who came to listen and those who listened to this presentation at home. I hope that in some time, we will have the opportunity to meet again. Then we will talk more with the people who, in the meantime, will be using these products. I always say that the best support for a medicine is the medicine itself. I'm curious about the experiences you will have with it. It would be nice if your company, in the future, organizes a meeting where we can discuss this further.
We share the same wishes here. Thank you, Professor. Have a pleasant evening.